Welcome to the next episode. I am Dr. Jaron Stout, owner and CEO of Collaborative Pharmacy Consulting. I am a national award-winning consultant pharmacist due to my efforts to improve the use of medications in nursing facilities. Today we're going to talk about anticoagulation. It's a topic I very much love to talk about. And one of the things that's interesting is I'm actually going to quote myself today. I was able to put together a study that took place between November of 2022 and March of 2023. So it finished 2 years ago, and in that we were able to evaluate the anticoagulation use in about 274 people over several states, and we identified that 63% of those were dosed incorrectly. And so I think when the era of the use of the anticoagulant warfarin ended, a lot of people thought the anticoagulation would be simplified because warfarin had hundreds of food and drug interactions, making it very complicated to dose. But you would dose it around a specific lab value. But with these new medications, you don't need to draw labs, but they have very specific dosing criteria. And that dosing will change a lot based on what the indication is. And that's something that is frequently misunderstood by most healthcare practitioners, especially in transitions of care. Now, if we're going to talk about these new aged anticoagulants, the best one on the market currently is called Eliquis. It has been shown to have a bleed risk that is equal to aspirin. So as far as anticoagulants go, it by far has separated itself from the pack. It has the lowest risk, the highest benefit. So that's the one we're going to cover today. We'll do a series of all the different ones that are available. But Eliquis has different dosing based on indication, like I said earlier. But if you have what's called atrial fibrillation, which is often called AFib, then you would need to dose it differently for that as you would for having a recent clot. Now, with AFib, you're going to dose it at 5 milligrams, and it's twice a day. Now, where I work in nursing homes, there are people who are frequently over 80 years old, or that are under 132 pounds, or that have impaired kidney function with a serum creatinine of 1.5 or higher. Now, if 2 of those 3 criteria are present, you will reduce the dose of Eliquis to 2.5 milligrams twice daily. Now, a lot of people get that mixed up. They will dose it this way for a recent clot, and that is not appropriate. Clotting does not follow that same dosing criteria. And I've seen hospitalists mix that up, and I've seen other primary care providers mix that up as well. So this is something that is commonly misunderstood. Now, if we're going to talk about other indications, the clotting is a very common one as well. That it's frequently shorthanded as VTE, which is short for venous thromboembolism. DVT is deep venous thromboembolism, and PE is just pulmonary embolism. So those are what we would use Eliquis for if we're treating a clot. It's typically one of those 3 terms that we would use. I won't get into the deep details of the differences between them. That's not really important here. Now, if we're going to give Eliquis to break up a current clot, then we need to give them a high-dose Eliquis for 7 days. You're going to have 10 milligrams twice daily for 7 days. Now, I have another video about amiodarone where I talked about loading doses. This high-dose Eliquis is not a loading dose. That is a frequently misunderstood concept of how this works. The reason it's dosed high for 7 days is because that is the duration in which you're at highest risk of developing a recurrent or subsequent clot. So, giving that higher dose of Eliquis reduces that risk of the subsequent clots. So, 10 milligrams twice daily for 7 days, and then you reduce it to 5 milligrams twice daily. Now, another aspect that is commonly misunderstood, you give Eliquis for 3 to 6 months after the clot. After that, you either get rid of it. If it was a first-time clot or it was a provoked clot, then you will just get rid of it after 3 to 6 months. Now, if it is a recurrent, a second-time clot, or if the clot was completely unprovoked, we can't figure out what really caused it, then you're going to be on longer-term treatment, but at the lower dose, the preventive dose 2.5 milligrams twice a day. A lot of people don't know that, and in fact, one of my biggest pet peeves is hospitals in a transition of care rarely give me the information to know if it was a first-time clot and when the last clot occurred. A lot of times it'll just say history of VTE or history of clots, maintain Eliquis. And I can't figure out when it was started, if it was a subsequent or a recurrent or anything like that. So it's very helpful to know when the last clot occurred and if it was a first-time clot or if it was unprovoked, provoked, etc. So these are very important aspects to understand if we're going to dose Eliquis correctly, especially in a transition of care. Now, this problem was much more problematic during COVID when people were handing out Eliquis because COVID was linked to a higher bleed risk. But unfortunately, some people were treating with a treatment dose, some people were treating with a preventive dose, and it got mixed up quite a bit. So notice I didn't mention anything about kidney function. I didn't mention anything about weight. It is for a recent clot, it is dosed strictly as a high dose for 7 days, treatment dose for 3 to 6 months, and then you eliminate it or reduce it to a preventive long-term prophylaxis. Now, the last indication we're going to talk about is preventive. If you go to the hospital and you are at risk of developing a clot because you are immobile for a short period of time, then it is wise to typically give somebody a preventive dose of Eliquis so they don't develop clots. If they have a history of clots, especially, then or a one-time clot in the past, then and they're not on anything now, then it's typical and appropriate to give them a short-term duration of Eliquis. Typically 2 weeks up to 6 to 8 weeks, depending on how long you're going to be immobile or what you're treating specifically. So these are components that are very important to understand when giving this anticoagulation with Eliquis, especially in transitions of care. Understanding how to dose it, what we're giving it for. And sometimes you'll even see that they have a history of clots and AFib. In that case, just treat it the way you would with AFib. But there are a lot of intricacies that go into dosing this appropriately. And the study that we put together a couple of years ago really showed that it is frequently misunderstood by healthcare practitioners. So there's a lot of education we need to do as pharmacists to make sure that residents understand how long to be on this, that our nursing staff understands how long to be on this, and when to reduce the dose, when to get rid of the medication, if it's going to be long-term, short-term, etc. So there's a lot to weigh here, and us pharmacists are extremely valuable in making sure we assess that correctly.